Please welcome Program Director of Diagnostic Excellence at the Gordon and Betty Moore Foundation, Dr. Daniel Yang.
That's it. Hi, good morning. Welcome to our spotlight session on engaging patients to improving diagnostic safety. I'm Daniel Yang. I'm a program director at the Gordon and Betty Moore Foundation, where I co-lead a philanthropic initiative that's focused on minimizing harm from diagnostic errors and advancing diagnostic excellence, which we define as timely, accurate, safe, cost-efficient, equitable, and patient-centered diagnosis. And the first question you might be wondering is, why should you care about diagnostic safety? According to the 2015 National Academy of Medicine report, up to 20 million Americans experience a diagnostic error every year. And while not all of these result in patient harm, those that do often result in devastating consequences for patients and for their families. It can result in psychological, financial, and of course physical harm and even death. These errors also exacerbate a patient's mistrust in the healthcare system. And so I wanted to make this interactive. I was wondering, by a show of hands, how many of you have either experienced a diagnostic error or know someone personally that's experienced a diagnostic error? And how many of you have experienced, or a loved one experienced, significant harm? It could be psychological, it could be financial, or it could be physical harm from these diagnostic errors. And so for those of you that raised your hands, you're in good company, unfortunately. A few years ago, the IHI conducted a nationally representative survey of 2,500 adults in the United States on patient safety. And they found that diagnostic errors were by far the most common medical error experienced by patients, accounting for 60% of all medical errors. And not only are these errors frequent, they're also consequential. An analysis of malpractice claims found that diagnostic errors were twice as likely to cause serious harm and preventable death compared to other medical errors. And lastly, these errors are financially costly to patients, to our healthcare systems, and to society. Diagnostic errors often result in additional testing and unnecessary treatment for patients, which can be costly, particularly for those that have high deductibles and high copays. It's also costly from healthcare systems from a risk management perspective. Diagnostic errors are the #1 cause of malpractice claims, and they result in the highest average payouts. And lastly, from a societal standpoint, it's estimated that diagnostic errors cost our country upwards of $100 billion in preventable costs each year. And so when you put this all together, the National Academy of Medicine, in its report, delivered a powerful call to action, one that I will extend to all of you today. The report says improving the diagnostic process is not only possible, it also represents a moral, a professional, and a public health imperative. Again, a moral, a professional, and a public health imperative. However, too often we view diagnostic errors as a failure of an individual clinician, as opposed to a failure of coordination within a complex healthcare system, or a breakdown in communication between a patient and a provider. Patients and caregivers who have experienced diagnostic errors can provide a unique perspective on both what went wrong and what we can do to do better. Simply put, we can't achieve diagnostic excellence without listening from and partnering directly with patients and their families. And so in our session today, we'll be hearing from leading experts on pragmatic strategies that you can bring home to your institutions on how to better engage patients within your healthcare system for co-producing diagnostic safety. I should briefly mention that there were no speaker conflicts or disclosures, and continuing education credits are available. And here are the learning objectives. In particular, I wanted to emphasize the third learning objective, to identify 1 to 2 actions that your organization can take to improve patient and family engagement in diagnosis. And so now I'm pleased to introduce my esteemed panel. First, we have Colonel Stephen Coffey, who is a career military officer and a devoted patient advocate. He's a founding member of the Patients for Patient Safety chapter, US chapter of the World Health Organization. Second, we have Dr. Segal Bell, who is an associate professor of medicine at Harvard Medical School and director of patient safety and discovery at Open Notes. And third, we have Dr. Hardeep Singh, who is a professor of medicine and director of the Center for Innovations in Quality, Effectiveness, and Safety, based at the Houston VA Medical Center and the Baylor College of Medicine. So first, I'd like to introduce Colonel Coffey to the podium to share some remarks, followed by Dr. Segal Bell, and then Dr. Hardeep Singh.
If I could start with a quote from one of my favorite authors, Charles Dickens. He once said that it was the best of times. It was the worst of times. It was the age of wisdom. It was the age of foolishness. Those words never rang more true than with the birth of my son, Stephen Coffey II. I call him Deuce. With his life, my life would change forever, and the world will be introduced to a living miracle. So I think it's important for us to start by framing this discussion, and I could think of no better way than with a coffee break, a little bit of a play on my last name. So we're going to roll a video for a coffee break. That video gets me every single time. Every single time. So Stephen was born on September 28th, 2012, and I was so excited because I knew I would have a son to carry on the good name. And if you look in the picture, you'll see that that's my hand cutting the umbilical cord. And I tell you, I think you guys gave me the dull pair of scissors because it was a lot more difficult to cut than it looked on YouTube. But the nurses took him away, and they did regular tests. And they came back, and they said that he had a high bilirubin, low glucose, and he was a little bit jaundiced, but they assured me he would be okay. And so that is really where I want to start, where we look at this diagnostic process and see where there's some gaps and seams that were in his care and how patients can engage. So if you recall back, we received a phone call from one of his providers, and we've been going back and forth to the hospital multiple times. We received a phone call from the provider saying, Stephen has this galactosemia. Now, this is 2012. And I had this provider on a speakerphone, and the idea was that if it was on speakerphone, my wife and I both could hear the same message. And the provider said, you should go to the larger military hospital and tell them that he has galactosemia. Now, put this in your mind, because there are barriers that start to pop up. There's a barrier of communication in that it's a speakerphone. There's a barrier of communication in that this provider has told me, the layperson, who is not familiar with galactosemia, to go to a larger hospital to inform other providers of galactosemia. There's a barrier in a sense that the provider actually had a very pronounced accent. So the barriers of communication started to really manifest themselves. And for those who are unaware or maybe have forgotten, galactosemia is a metabolic condition whereby his body cannot break down the simple sugar galactose found in human and animal milk. So we go to this hospital and we're told by the providers, we're not really sure if he has this galactosemia. It seems like it's a trait. Don't change his diet. It's just a trait. And we're discharged that exact same day, and we come home and we get a phone call from the smaller hospital that says, no, he has galactosemia. Change what you're doing. So now there are two laypersons who are in between providers with two different diagnoses. And we tell the smaller institution, the larger institution said, no, it's just a trait. And the smaller institution, despite having the right diagnosis, said, defer to the larger institution. Size does not always matter. Fast forward to Thanksgiving, and I am really excited as a parent because I'm about to go out to do my Black Friday, Great Thursday shopping. I am in comfortable clothes, ready to do battle at Walmart to get the G.I. Joe with the Kung Fu grip. And I get a phone call from my wife saying, something's wrong with Stephen. We need to go back to a hospital. And they look at this lump that's on his leg, and I go to the hospital, and because I'm in these comfortable clothes, I feel I'm dismissed. My concerns were disregarded. I was labeled as being an overreactive parent. I was worried about fatty tissue or swollen lymph node. I was not heard as a patient caregiver. The doctor said, well, if it gets worse, come back. The very next day, I came back. And because the swelling had spread from now his leg to across his genitals, I was really concerned. But I looked different this time. They didn't know that I'm this colonel with this TSSCI and all these other letters and accoutrements behind my name, but on that time, they did. And tests were run. I was treated with a little more respect. That introduced in my mind this idea of a bias. We were eventually medevaced. And we were sitting in the PICU. Now, I did not know that on November 28, 2012, we're sitting in the PICU. I didn't know that the PICU is where we send our sickest kids. I'm not a medical provider. And I'm sitting at MedStar Georgetown University Hospital, and I'm in the PICU. And this resident is presenting my son to one of the attendants, and they say, this is Stephen, our 2-month-old from an outside hospital who has fulminant liver failure, secondary to galactosemia. 5 days later, Stephen received a liver transplant at the very tender age of 8 weeks old. Youngest in the country in 2012 to have had a transplant. And so when I think about his story and I think about where we are, I say now he's a 10-year-old, he's thriving. We've published a book, Baby Stephen's Gift of Life. He's a 10-year-old doing normal 10-year-old things, but it causes me to wonder and to question, what if? What if the provider had called ahead to inform the other hospital that we were coming of his condition? What if that person that did intake, that tech who did intake, realized that there were biases that made up their decisions to diagnose or how they documented? What if there was consensus on a very deliberate and conservative approach toward treatment? Would Stephen have had a liver transplant? And so I'm very excited today to really tease out some of the threads and the themes that are in this tapestry of medicine that we can show where the partnership between patients and providers, when done properly, improves quality and safety in care. So with that, I will hand it over to my colleague, Segal. Thank you so much.
Fantastic. Really well done. Thank you.
Good morning, everybody. Wow, that's nice. Good morning, IHI Patient Safety Congress.
Good morning.
Yes. So this is just so exciting to be here today with you. It's a refreshing change from Zoom, am I right? And I'm so honored to be here with this esteemed panel. And I just want to, before we start, extend my gratitude to Colonel Coffey and his family for sharing their experience. I'm sure you feel quite the same, that it really exemplifies the power of patient voice. And there's so much that we can learn from this story. But today I want to focus on just 3 things that I'll try to tell you about in 5 minutes, which is okay because I'm doubly caffeinated and from Brooklyn. But really my goal is to leave you with maybe one thing that sticks with you and that will carry into our discussion, but also that you might carry home with you to your own organizations and maybe just shift just even the smallest bit the way that we think about patient engagement in diagnostic safety. So let me get started here. And I want to say that one thing that really stood out to me when Colonel Coffey told his story was this phrase: I felt like I wasn't heard. And this is the tragic of diagnostic errors, where we hear that patients and families have something important to tell us, but they feel like they weren't heard. In fact, it extends beyond diagnostic error to many errors, actually, where patients and families have some knowledge that we haven't uncovered. Well, in this 2017 IHI survey that Daniel mentioned a little earlier to you, reflective of the US population, what we found is that not feeling heard was actually the most common contributing factor reported by patients and families who had experienced, by their own self-report, a diagnostic error, 596 patients and families. And I will tell you that in pilot data now from a recent study we completed at Boston Children's Hospital, data courtesy of my colleague Fabienne Bourgeois and Nick Hart, when we looked at the idea of not feeling heard among patients and families who prefer a language other than English, limited English proficiency, not feeling heard was 5 times as commonly reported by those individuals. So it's not surprising, but it is quite sobering when we think about the barriers to getting it right. Well, what else do patients and families say? And I will tell you that you can probably see some commonalities here in what Colonel Coffey just told us about. So they talk about problems with access, but it's not just access to care. It's really interesting if you listen closely. It's access to information, access to actually entering the diagnostic process with their clinicians. They'll often say, well, something important was missing, and sometimes it's even the main complaint. They'll say, I didn't know who to call or when, the absence of this contingency planning that we know is critical, particularly when uncertainty is high. They talk about disrespect, they talk about misalignments, they talk about confusing and conflicting information, which we heard again here in this story. And so what we were noticing is that patients and families, they really use different words, right? Different concepts than clinician-derived diagnostic error, even when you look across the NAM model. They don't talk about failures of integration of information. They use different terms, which means that if we want to engage patients and families, we need to understand these terms so we can ask in ways that make sense. So it occurred to us that we were then probably missing some really important events. And that's a missed opportunity, not just for the individual patient and that diagnostic journey, but a missed opportunity for organizational learning. And here's why. So when I show this image, I want you to imagine for a moment that you are doing these, New Yorker style contests where you have to come up with the title or the caption, right? And think about, like, what is the word or two that describes what you're seeing here? You got it? You got it captured? You ready? Okay, everybody's committed to something. When I ask, most people will say something about perspective or perception. I showed this slide to some public health students recently, and one kid said, it's a giraffe drawing a lady. I thought, okay, got a realist in the crowd. Okay, perspective. So isn't it interesting, right? What we see actually really depends on how we look. And patients and families, they have a unique vantage point, right? They have experiential intelligence. Nobody knows what it's like to be a patient as much as a patient. Probably Deuce, Stephen too, could teach us all a thing or two about galactosemia. I'm guessing, right? They're also the connecting thread between all different appointments, visits, hospitalizations, urgent cares, emergency rooms. They hold that continuous knowledge, sort of like a diagnostic memory. And we visit 20 minutes at a time, right? And they know what happens outside the hospital or clinic. So they are actually living this diagnosis or this diagnostic process. Well, my good friend Eric Thomas and cherished colleague says that there's a long-standing patient safety tenet that multiple perspectives are needed to fully characterize and understand a problem, and then to design solutions. So what we did is we gathered a multi-stakeholder advisory group and looked at 2 data sets, large ones, of patient-reported errors to develop a patient-centered framework of diagnostic breakdowns. Again, how do patients' families describe these processes? And when we applied that framework to over 22,000 patients who read their ambulatory visit notes, we found that over half of them who reported a diagnostic breakdown actually identified a potential blind spot. Now, what are blind spots? Safety issues that patients know about, but that the clinicians or organizations may not see. And this term was coined by Gillespie and Reeder when they studied letters of complaints across the UK. And what they found is that blind spots were correlated with safety risk. So what kinds of blind spots in diagnostic safety? First, misalignments, right? We're going to hear that word more and more. Wrong symptoms being described or breakdowns in explanation and next steps, just like happened in Colonel Coffey's story. There were omissions, so things that, of course, providers can't know about because they're not there. And that might include missing information. It might include not listening. Blind spots between visits, things like problems with access or problems with tests and referrals. And then a fourth, smaller blind spot of multiple low-grade cascading kind of problems where each in and of themselves doesn't cause a problem, but together does. So what we can see here from this data and from the original blind spot study is that patients really hold key parts of the puzzle that are not necessarily captured in traditional safety metrics or EHR triggers. And this really gels, right, with emerging concepts of how we think about diagnostic safety, concepts like situativity or distributed cognition. Each party holds part of the puzzle, but none holds it all. And we really need to figure out then how to bring that information together. I will mention that many of these patients that found blind spots actually acted on them voluntarily. And so there's several sort of policy implications that come from this. Again, I'll only mention 3. The first is that patient involvement in diagnostic safety is essential to optimize safety. So these kind of data, if we believe that there are things organizations can't see, that we need to learn about these problems in order to improve our system resilience, means that patient engagement is no longer an if, it's a how, right? How do we do it, at least for those patients and families who are willing and capable? 2, patient good catches should be invited, supported, and celebrated. So this is part of the culture piece, the organizational culture. Many of you are at organizations where clinician good catches have programs, right, are supported and are celebrated. Where are the patient good catches, right? Has anyone heard of one? They're out there. 3, sharing notes provides a new scalable platform for patient engagement and diagnostic safety. So had they not read their notes, many of these patients wouldn't have even known that there was a problem. So I'm going to end here with the what if exercise. And I was reflecting on Colonel Coffey's comments, and I thought to myself, what if the Coffey family had access to the information they needed to make it safely across these multiple, actually, transitions of care? And when I think about what if and the way that it's been used by several patient advocates in the field, access to that information is game-changing. It can be life-saving. What if he had read the note that said galactosemia and knew exactly what we were talking about, or shared that information with the next provider? When I think about the what if exercise, I'm also reminded of this term of like, sort of thinking about work as imagined versus work as done, even though in the classic safety 2 approach, this is applied to routine practice as opposed to adverse events. But we know that patients and families are key members of the diagnostic team. And we know that teams need a shared mental model in order to perform effectively. But how do patients, families, and clinicians actually create a shared mental model of the diagnostic process? That's the kind of question we need to focus on moving forward. All right, so a recap. 3 things: the importance of feeling heard. Think about it, like, why is that so important, even in your own lives and relationships? The value of multiple perspectives and the opportunity to detect or prevent blind spots, and sharing information to help get the diagnostic team on the same page. I'm going to pass over to Hardeep.
Okay. So if I can have my slides up, that would be great. So we're going to make this session a bit interactive, but I'm going to tell you a little bit about what we found, just sort of underscoring the point here. I've done about maybe 100,000 record reviews over the course of my professional career, either supervised or done them myself. And I would say that the information you get from patients and families directly really is very complementary and unique, and you don't get that, as Sigal mentioned, from these medical record reviews. So one example is this study that we did where we looked at 184 unique diagnostic error narratives from patients and families. And what we found was information that we have never received from all the medical record reviews that we've done over my entire career. So this is when behavioral and interpersonal factors, the theme of the doctor did not listen to me, was really, really very prominent. And so we thought that this is an excellent way to complement whatever we do in our patient safety work as far as diagnosis was concerned. I'm a researcher, so we have also looked at research findings. How do we improve the research agenda for diagnostic errors? So we talked to a lot of researchers over time and figured out what to do, what to focus on. And then we thought, well, let's ask the patients as well. What do they think should be the research agenda for diagnostic errors? And sure enough, we get very unique perspectives on what should be done in diagnostic error research. So you can imagine number 1 was, of course, coordination and communication, which is no surprise. But look at number 2. How to accurately track and report diagnostic errors at a health system level was the second most highest ranked agenda item, what patients and families thought that we should work on as researchers. Now, that's something that health system folks who are here can help with, correct? I mean, this is something that we should be able to do. So where do we go next? I'm hoping that for the next remaining time, I believe we have about 30 minutes still left, what we should talk about is 3 things. One is we should think about how to test novel methods to engage patients in improving diagnosis, but not just improving diagnosis, how to reduce diagnostic error, which is related but different. Second is, how do we get information from patients on diagnostic safety events, and how do we use that data? It's easy to say, it's not really easy to do. Most of this has just been done in research settings. So we really need those, and that's the third point here, is implement pragmatic tools and strategies which can help us do those 2 things. Get patients to improve diagnosis, reduce diagnostic error, as well as report patient safety events, whether it's through patient complaints or other data sources, including reading their own notes. So we're going to interact with you. So I want you to go to slido.com on your phones, or you can just scan this QR code. And I want you to take a couple of poll questions before you think about what questions you want to ask us. Ask tough questions. And guess what? If your question's really good, the other audience participants will rank your question, will give her a vote, and the highest voted questions will probably be the ones which will be asked by Daniel, who will moderate the discussion. So let's go to the first question. Our healthcare organization actively seeks patient and family feedback to identify and understand diagnostic safety concerns and addresses concerns by co-designing solutions. How many of you think you're doing this well? got about 150 or so participants, 185, really good. 200. I'm going to give it another 10 seconds. I'd really like to talk to the people who said, yes, we have fully implemented this practice for diagnostic safety-related conditions. I want you to come up to the stage after we're done. Okay, so more than half of you say we have not considered implementing this practice for diagnostic safety concerns. Huge opportunity for you here. It's great, love this. Okay, next question. Our healthcare organization encourages patients to review their health records and has mechanisms in place to help patients understand, interpret, and/or act on diagnostic information. By the way, both of these questions are derived from the SAFER-DX checklist, which is freely available on IHI's website. We developed this checklist for healthcare organizations to do a proactive risk assessment on their diagnostic safety practices. So you can look at the checklist items, 2 of them are here, and we did this work in collaboration with IHI. So it should be a useful tool for most of you. Okay, so we've got about 300 plus participants. About half of you say, I'm unaware of any systematic efforts at my organization to do this well. Again, a huge opportunity for us. So I'm hoping that some of the discussion that happens in the next 30 minutes or so could stimulate some of us to take action. And again, I want to really talk to the ones who are the 5%, yes, we do this practice well. Come talk to us. All right, okay. So you can put in questions. We're going to take the questions down for just a bit so we can have a little 5 minutes of discussion, and then the floor will be yours. Thank you. Over to you, Daniel.
Wow, what a great set of presentations, and thank you for that story. Segal, I'd like to start with you. In your presentation, you said involving patients is essential. It's not a matter of if, but how. So can you tell us how, and how does that look different than what care normally looks like today?
Yeah. Well, it's an evolving answer, but I think starting from the approach of really thinking about the diagnostic team and that patients, families, and care partners are part of that diagnostic team can frame our discussion of how to move towards that goal. So the first thing is with any team, you want to avoid information asymmetries. And so sharing information is a key first step to really get all the players together on the same playing field. And there we talk about things like open notes, being able to read your healthcare information and how the doctor is thinking about your health conditions. With open notes, we know that sharing that kind of information can help patients remember diagnostic tests and referrals. It can improve relationships, including trust in the clinician. So maybe those closer relationships can encourage asking questions or speaking up in cases where patients might feel intimidated to do so. And third, it gives them the opportunity to, of course, identify potential diagnostic breakdowns or even blind spots. But in order to glean these benefits, patients have to actually read their notes. They have to actually get to their notes. And the proportion of patients who are on patient portals or who actually go on and find their notes through 17 clicks or whatever it takes to get there is quite small still across the country. Some organizations do it better than others. And so I think from an organizational standpoint, having a way to really help your patients understand where that information is, developing educational programs around, why you read your notes, what is the main purpose of the note, what do you do if you find something that's not quite right in your note. Those are the kinds of things that can really improve the impact of sharing that information. That's kind of low-hanging fruit, right? That's like most organizations are doing that, whether they're doing it well or not because of the Cures Act and federally mandated sharing of electronic health information. But if we take it one step further, using tools like one we recently developed called RDX. This is a pre-visit survey tool, so anyone can implement it in every EHR and patient portal functionality that is out there now, a pre-visit survey. And we asked 3 questions, and these questions were really identified based on what we learned from patient-reported breakdowns. So we wanted to be able to, the goal of this tool was to bring actionable information to the point of care before the visit when they are sitting in front of a provider and something can be done, and to use existing workflows so that we are not increasing the burden on providers or on patients actually as well. And the 3 questions are these. 1, what are your top priorities for this visit? What do you want to have happen? And the goal there was really about this issue of alignment, right? Preventing the misalignments by understanding what matters most to patients. The second was about history, and the goal there was to avoid some of the errors that we saw in medical history because patients are using their own words. And the third was about potential diagnostic breakdowns, including, did you feel heard? Including problems with tests and referrals, and then other sort of any general breakdowns. And when we implemented this, what happened is that information kind of flowed into the EHR so that the provider could see that information at the time of the visit. So what happened? Patients used the tool. They provided meaningful information almost over 95% of the time. Some, about 10%, reported breakdowns like not feeling heard, test referrals, et cetera. But many provided positive contributions to the diagnostic process, things like having been seen in an ER for the same problem within the last 2 weeks, or other perspectives from multidisciplinary care, or really being able to help the provider to weave together the diagnostic process at that point of care. So this is a way that patients, families, care partners, clinicians are co-producing safety, and something that we can all think about implementing in our own healthcare systems.
And can you just remind us what the name of that tool is and where we can find it?
Yes, it's called RDX, O-U-R, DS,
okay.
our diagnosis, yeah. And it is available through, if you go into the Open Notes website, for example, and type in RDX or diagnostic safety, and it's also in some publications, one in JAMIA and one forthcoming. Yep.
Thank you. Colonel Coffey, I wanted to turn to you. In your family story, I couldn't help but notice that there were differences between what it means for a patient to feel safe and how healthcare systems view safety, which is oftentimes driven by just the outcomes and not necessarily the process of how you get there. So in your experience, what does it mean for a patient to feel safe? And what do you think healthcare systems can be doing differently to really changing the perception of safety?
Well, really great question. So, you know, I'll tell you, I've had a great career in the military over 20 years, or 22 years total. And in that career, I've had a chance to work in some places like the Pentagon, the White House, and the National Security Agency where I'm at now. When I take people to the Pentagon, they're amazed. And the reason they're amazed is because they've never been there. And I correlate that to medicine when I say this simple word, that it is a significant emotional event. Every single time my son and I go to the hospital, 10 years post-transplant, it is still a significant emotional event. So when I juxtapose that with my military career and I take any of you on a tour of the White House or a tour of the Pentagon and you see that we have a Starbucks and a Dunkin' Donuts on the same floor, we're competing to do the best pumpkin spice latte, you're amazed. But when I go to the hospital with my son, 10 years post-transplant, it's still a significant emotional event. I recognize how cold and sterile the walls are. You may not because you see it every day. So when we talk about this idea of feeling safe, it is really coming from the perspective of understanding the patient, having this mindfulness that for them, for us, coming to the hospital is a significant emotional event. And so you think about when we talk about what can you do to get through that piece, and what I would tell you is beyond the mindfulness piece, it really goes back to making sure that everyone has this psychological freedom and that culture of psychological freedom that we feel like we're being heard. And I mean that because from everyone from the white coats and stethoscopes, the doctors and providers, down to your housekeeping and environmental services, everyone has a voice and has to be heard. And when that culture is created within the institution, it also bleeds over into how we care for patients because it becomes ingrained in us that everyone's voice matters.
Thank you. Anyone else?
Do you have any comments, Hardeep?
I think we've got a question for me that Denny has lined up, which I want to get to.
All right, okay. Well, Hardeep, you talked about leveraging patients for purposes of learning about both errors in diagnosis as well as strategies to improve. So I was wondering, one, if you could tell us what are these different sources of patient-derived data, and what are some of the challenges that your group has encountered in leveraging them?
Yeah, this is what I really want to get to, because it's important for this audience to know what are the sources, what are the challenges. This is easy sort of to talk on stage, but it's really hard to do. So I'm going to tell you what our experiences have been. Number one, so what are the existing sources? Patient complaints. How many of you analyze your patient safety complaints, your patient complaints for safety data? Looking at safety signals, very few hands. It's harder to look at diagnostic safety signals because it gets lost within all that clinical care, that, sort of that big box of clinical care patient complaints that they are. Number one. Number two, you get surveys from patients, right? The CAP surveys. How many of you read the narrative text of those surveys where patients write stuff down? Very few hands are going up. The real diagnostic safety stuff we've seen is in those patient narratives that they are writing in those surveys because they are really upset or they are mad because something bad happened. We're not looking at those very seriously. Of course, we need sort of help. So what's happening is the signal is getting lost. We really need to pull out the signals from the existing safety data. Number two, what are the new sources of, or what are the mechanisms to get data from patients? So we're talking about open notes. So we invited patients to read their notes, to look and see, are you finding any problems here? So we created an instrument. It's called the SaferDX Patient. The SaferDX Patient walks the patient through an entire exercise of reviewing their own medical record to look for diagnostic safety concerns. So we identified a high-risk patient population that we thought, this population might have a diagnostic error. We invited them and we asked them, can you look at your notes? Because we are finding something that might be, because you came to the urgent care, then you got sent home, then you got admitted a week later. We think something may be of concern to you, so why don't you look at your medical record and tell us if you are finding anything. And so we created this instrument called SaferDX Patient, and we had them look at this. It was really hard. We sent thousands and thousands of invitations to patients, but very few responded. So we did try our best to engage them. Now, the ones who responded did find something, so there's huge opportunity here. They were able to review their medical record according to our instructions given in the SaferDX Patient instrument, and lo and behold, they found information that we then reviewed for signals. Going on to challenges. Because patients found stuff, that didn't necessarily mean that the clinicians who reviewed the medical record at the same time also found stuff. There was lack of concordance. Patients said there was a concern, and when you had clinicians read the same chart, they said, no, we're not finding any concern. So there's always different perspectives. And then lastly, this stuff is hard to do, which is why we're not doing it yet. So we created, I think the implementation would be the biggest challenge in doing some of these things. So we could gather new sources of data, we could leverage patient complaints, we could look at all the survey data that's coming in, we can use open notes, but who in your health system will take this data, implement all these mechanisms, learn from this data, and then use it for improvement? That's another big next step that we have to take. And I think that's where that implementation gap comes in, where we've developed a tool, again, DX in it, MeasureDX. MeasureDX is a freely available tool available from AHRQ that helps healthcare organizations monitor diagnostic safety through multiple mechanisms. One of them is patient-generated data. So I would encourage everybody who's interested to go to MeasureDX. It's, again, put MeasureDX AHRQ, and you will see that the strategy, one of the strategies, is exclusively focused on patients and how to get data from patients.
Thank you, Hardeep. Well, let's get to the audience questions. We've got a lot of them. By far, the most popular questions are actually the first two, which are very similar. How do we equitably roll out patient reporting so that vulnerable populations, for example, those with low health literacy, their voices are heard?
Did you have a paper on this? Sigal has a paper on this, so I'll let Sigal take this.
Did you write this question, Sigal?
No, I didn't, and that is a tough nut to crack. I will say very humbly. So, I think I have two thoughts about this. The first is that sometimes we shy away from interventions because we're afraid they don't have an equitable opportunity for all individuals. And I think that's it's a real challenge to shy away because you sort of have to learn how to use the tool before you can then learn how to make it available to everyone. So I'll just state that because I think even our opportunities in innovation are tampered to some degree because of coming out of the gate with that concern. Having said that, it's a real concern, and I think we need to think about, particularly with electronic innovations, how to avoid the worsening or the widening of disparity gaps due to unintended consequences of implementation. I think AI ultimately will help us with some of that. I was speaking with Gary Weissman yesterday after his presentation on AI, and it's not that far down the road where AI tools will help. They do it already, translate notes into whatever grade reading level you want them to do. I think there's also language translation coming down the pike with similar technologies. And the question that remains for us is, how accurate is accurate enough, right? Because that's the problem we all consider with AI. So are we willing to go with 98% accuracy? Are we willing to go with 99% accuracy, considering the trade-off of bringing information to more people? So I think that's a really difficult one that we'll all have to grapple with. But the last thing that I'll say is that it's one about challenging our assumptions. So from the beginning of time with open notes, going back over a decade, people will often say like, oh, this is a really great intervention for my tech-savvy patients. And what we've learned over time is that actually it's patients who are less educated, patients who come from more diverse racial and ethnic backgrounds, even patients who prefer a language other than English, and this one is shocking because notes are not translated, who report as many or more benefits from having access to their notes. Now, why would that be? If you think about the status quo of just sort of like going into a visit that's very rushed and actually, explain to me this one, the clinician has the same amount of time, even if there's an interpreter there, so there's, twice the volume of conversation that's happening, and then the patient leaves. And that's what they're left with, right? And we know 40 to 80% of information is forgotten, and it's worse with language barrier, difficult news, all the rest. But now they can at least go home and find a loved one, a friend who can help recapture what happened there with the notes. So even if it's not in their native language, which of course would be preferable, it's better than nothing. So a work in evolution, a work in progress is what I would say at the moment.
And let me add to that, and I think we have to sort of redefine low health literacy in terms of in this information age. I've had my colleagues and friends who are, like computer science professors and PhD this and PhD, highly educated, who call me and ask, my chloride's 106, what does that mean for me? I'm looking at this in the portal, the doctor didn't call me for anything and I don't know what to do, so I'm calling you. How many of you sort of get calls like this, right? From patients are like, I'm not sure what this means. So we're releasing all this information, but we're not necessarily providing patients the support mechanisms so they can understand this information and put it to good use. And I think that's sort of one of the gaps here that we think that traditionally people will understand if they're educated, but actually a lot of people are not understanding. I had one computer science professor who told me he has 3 different portals and he can't figure out how to use any one of them.
Yeah. So I want to add one part of that as well. And so as a military guy, I really believe in culture. And so, in my mind, culture will eat strategy every day for breakfast, lunch, and dinner. Culture eats strategy every single day. So that really comes to what does our C-suite value? Because that sets the culture, which then permeates throughout the organization. And when we talk about how we make equity rather for patients, it really starts there. But it also goes into this idea of representation. I will never forget, I'll tell a really quick vignette. I was in a hospital, I was looking at the wall of residents, and I'm looking at this wall, and there's not a single person of color that looks like me. And you know, they've got 3 years of pictures here and not a single person there, so that is not a one-year fix, right? So culture and representation matters. Because when there is vulnerability, you start to build transparency. When I see someone that looks like me that is in a position of leadership or a position as a provider, it makes me feel more comfortable, and then I'm able to understand and be more of a partner. Culture eats strategy every single day. The last thing I'll give you is that simply we have to think of healthcare as a system, as an ecosystem, right? We oftentimes look at medical care and say, well, medical care, I'm taking care of your leg because that's what hurts. But when we look at medical care as a healthcare ecosystem, you start to put into your mind, do they have good drinking water when I'm prescribing something? Flint, Michigan, Jackson, Mississippi. This is not, 50, 60, 80 years ago. Do they have access to care? Do they have all these other factors that are institutional that really build into the biases that we often have and the distrust that minorities often have of medicine? So when you start to have that representation, when you start to look at the culture, you start to change the face and feel of medicine.
Well, I hate to give a technological solution to what is clearly a social problem, a cultural problem, but I would underline the AI question. Maybe I'm biased because we're in Palo Alto and it seems like you can't have a cup of coffee without talking about ChatGPT. But one of the use cases that is really quite remarkable that people are using today, first of all, patients Google stuff.
Yes.
Everything, right? So the fact that they're not going to be, Bing AI these things, the fact that they're doing it now. But one of the most interesting use cases that I've seen is actually patients querying or better understanding what they're seeing on Open Notes to make sense of it.
Yeah.
Like, what does this lab value mean? Instead of calling you Hardeep, they'll probably just go online to start, right? So maybe we'll see these calls less frequently. What is the accuracy of this information? But I do think that whether or not we would recommend it, whether or not we think it's good or bad, people are doing it. I would say that the quality of information, despite some of the concerns, on average is much better. And physicians are using it, right? So I'm low health literacy when it comes to reading a note from ophthalmology. I can't make any sense of it, and so I'm Googling it or I'm going to be ChatGPTing it. So I would say that we're kind of reaching a different, let's say, relationship between patients that they can actually query and make sense of, not in a search, but in an actual conversational way. I think it's pretty interesting.
Yeah, in one of our studies, we looked at when we're releasing test results directly to patients, the first thing they do is they try to call the doc. The second thing they do is try to Google. Yeah, so they are doing it, you're right. So we need to be able to provide patients the right and the reputable resources, because there's not everything on the web is not as reputable, right? The other thing is they also use differential diagnosis generators. Regardless of whether differential diagnosis generators that are available, that are sort of for patients to use, they put in their symptoms, or they get some sort of a list of diagnoses they may have. It's interesting that they don't know necessarily what they have, but we did a study and we asked them, did you find this information useful for your ultimate diagnosis? And about half of the patients said that information was useful to them because it was from a reputable differential diagnosis generator. So your point is very well taken, that we're in a new information age, and as long as we have the right tools to support patients, we can do a lot of good.
I would just add that everybody's worried, of course, that the first thing they do is call, but here too there's an opportunity for how we embrace our own approach to how we order tests and referrals in light of immediate release to patients. So I think yesterday one of the main foci, plural, of the keynote talk was sort of moving things upstream. And if we think about it, rather than be reactive when a patient reads their test result or note. What if we move things upstream and say, I'm about to order this test, and here's the reason why. And here's what I'm expecting we're gonna find, but here's what we might find. And then there's also some patient preference around this. Do you want this test released? Do you want to see it on the portal before we talk, or do you want me to call first? And so, don't look on your results, just when you're pinged, or maybe shut off the pinging as an organization for test results. So there's multiple ways that we can embrace this that really require us to be quite thoughtful about how we're doing things, and maybe even more thoughtful about which tests we're ordering. Why am I really doing this, and what am I thinking about? One thing we say at Open Notes is, say what you write and write what you say. The patients don't want surprises, right? And why not do that? Transparency requires transparent doctoring, transparent nursing. A lot of our clinicians will say, well, I don't have anything to hide, right? So have those conversations. That makes for better care too. I will say, coming back to the vulnerable patient comment, that they are looking things up too. Everybody's looking things up, and yes, the resources are not always quite as reliable, but here's a vignette of a patient with COPD, and she'd come into the doctor's office with COPD exacerbation. Now you can imagine how difficult it is to understand what even that diagnosis means. And this patient said every time she went to the doctor's office, she would turn the words over in her head over and over and over again, just to try to hold on to them long enough so she could go home and look them up. And it wasn't until she had access to the notes that she could then understand what her diagnosis was. Right? So, we have to challenge our assumptions about how we're thinking.
One thing I must add that, for clinicians, I think some of the points you're making is...
we are at time.
Oh, we're at time. Okay. All right.
Oh, no.
I'm sorry. We could go on, clearly. Maybe find us afterwards. But first of all, I want to thank you all for attending. I want to just share a few logistical remarks before you head out. For those of you that are interested in this topic and have registered for the couch conversation on diagnostic excellence and measurement, it is directly following this. In the exhibit hall. And lastly, if any of you are interested in the topic of diagnostic safety and diagnostic excellence within your organization, the Moore Foundation is sponsoring 2 scholarships for folks to participate in the IHI Fellowship. So anyone that has a project around diagnostic safety that wants to see it move forward with the support of the IHI Fellowship, I'd encourage you to go on the website. The foundation is providing scholarships for that. Thank you for joining us. The conversation will continue. We look forward to talking to you more. Thank you all.